Hi, and welcome to Healthy Living. I'm here today with Kelly Presnell, Director of Marketing and PR here at Hilton Head Hospital. We're going to talk to Dr. Jason Schneider today. Talk with me a little bit about him.
Yeah, Dr. Snyder, he is a interventional radiologist that has started at our hospital. He specializes in breast imaging. That is his main focus and love. He's fellowship trained, and it is a very high quality service to have those dedicated fellowship trained physicians specializing in a particular service.
And what's interesting is that we are here at the Bluffton Medical Campus and the whole breast center is here.
Right. That's part of the plan with the Bluffton Medical Campus, is that we were able to move the breast health center and imaging into one space so that they could, because they work so closely. It's so important to have a team approach and for the two physicians and the rest of the staff to work together. That is what provides the extraordinary and the world-class care.
I'm really excited to talk to Dr. Snyder.
Yeah.
Stay with us. We'll be right back here on Healthy Living.
Dr. Joyner. Dr. Joyner,
When you're sick and need to go to the ER, it's no fun to wait. There is a smarter way. Check in online at HiltonHeadRegional.com and skip the ER waiting room. Hilton Head Hospital, the smarter way to ER.
Pain. It can be different things for different people. A shoulder that takes you out of the game. A knee that stops you in your tracks. Ready to return to a better you? Hilton Head Hospital is here, right in the Low Country, to help heal what hurts. From diagnosis to treatment to full recovery, our fellowship-trained orthopedic specialists are committed to getting you back to your best. Hilton Head Hospital. Extraordinary care right here at home.
We are back here on Healthy Living. We are here today with Dr. Jason Schneider, and we're talking about radiology. We're here at the new Bluffton Medical Campus, which is absolutely unbelievable.
It is
nice.
nice.
It is such a treat. You look all relaxed. And thank you for joining us today.
Yeah, thanks for
I'm
having
really
me.
interested first in talking a little bit about your background, how long you've been here, and then how you became interested specifically in radiology and then mammography.
Sure, certainly. Debbie, well, I did all my training in Birmingham, Alabama, and I went in private practice in Georgia. And
Where in Georgia?
I was in Atlanta at the Piedmont Healthcare System.
Oh, yeah.
And then decided to go into mammography, breast imaging, and did my fellowship at MUSC up in Charleston.
Okay.
And heard that Dr. Herman, Jenny Herman, great breast surgeon, was working down here, and was fortunate enough to come down here and work with her.
I'll tell you what an impressive setup you all have right now. Talk us through a little bit about how it's actually going to work for you here at the breast clinic.
Well, right now we do all our screening mammograms, or we do some of the screening mammograms here, and we still do screening mammograms at the hospital.
Okay.
Most of the diagnostic work is done here as well, but I will be at the hospital doing some diagnostic work. All the breast MRI work is done at the hospital right now, including all the breast biopsies. And then all the localization procedures for surgeries are done at the hospital or at the Okatee campus. So patients can still get their mammograms at either place. Right now, since all the diagnostic work is here, and my office is next to Dr. Herman's office.
Which, it's unbelievable, y'all. Wait till you see it.
So, you know, if there's an evaluation, if you're a patient that needs evaluating, or you're seeing Dr. Herman and there's some imaging involved, then Dr. Herman and I can discuss your case right there on the spot. And so I think it's going to be very beneficial, and that's unique in breast imaging, to have the breast surgeon and the breast imager working so close together.
Take me through a patient scenario and why for you it's so wonderful and why for the surgeon it's imperative too.
Well, oftentimes breast cancer patients, the case can be very complicated. Okay. There's a lot of factors involved. And sometimes while
For example, when you say there's a lot of factors involved, what would
during, as far as surgical planning goes, and as far as future treatment options go, a lot hinges on some of these early decisions.
Okay.
And so I'm able to go over certain decisions in the decision tree with Dr. Herman as far as patient history, kind of what the patient's thinking as far as
presenting profile, things like that.
Exactly, surgical options for them in their mind. And so it kind of allows us to get down the road of diagnosis a lot quicker.
One of the things that's really interesting to me when many people think of radiology, they think that you are simply reading an x-ray. Can you talk us through some of the other things that you do? Because it's much more complicated than that. And I told you my son's a radiologist too, so I know just enough to be dangerous. But what I do know is that you are the critical diagnostician. You are the one who basically sees the nuances and sort of helps guide what the treatment options will look like.
Right. I mean, sometimes we've been called the physician's physician.
Yes, and that's exactly.
And so, I mean, one moment I'm talking to an orthopedic surgeon, next minute I'm talking to a cardiothoracic surgeon or a breast surgeon or a primary care physician or a pediatrician. And so all the whole spectrum of diseases generally ends up going through radiology, getting an x-ray, an ultrasound, CT scan, MRI, PET imaging. Oftentimes we find something on imaging or a physician is suspicious clinically. Then we look for that with imaging, and if we find it, we need to maybe do a biopsy, and we can use imaging guidance, ultrasound, CT, x-ray, mammo, MRI, all that is guidance to find that area and then biopsy it and find out exactly what it is. So everything kind of converges on the imaging.
With you.
Exactly, as far as imaging goes in the radiology department. So it's exciting. We get to see most of the pathology that comes through the hospital, all the good cases and interesting cases, and so it's a dynamic, very dynamic workday.
How has radiology shifted or evolved since you've been in practice, and then what do you see as kind of the future?
Well, I have seen the technology improve.
Okay.
When I first started, the CT scanners were 2 slice and 4 slice. Now they're 32,
yeah, that's what you all have here,
slice,
don't you?
Exactly. And there's a heart scanner out there that does 256 slices and 1,064 slices. The technology has just gotten better. It just keeps getting better. The MRIs are getting better. There's a lot of focus now on molecular imaging, hooking up some of these radioactive particles to nanoparticles, and so there's big work in that right now. And so some of that stuff is kind of right on the edge, on the cusp of coming out.
When you are looking, when you have an image in front of you and you are trying to look for pathology or whatever you're looking for, do you ever find things that are a bit incidental or things that you just, you know, happen to see?
Sure, we call those incidentalomas.
Okay.
And how do you deal with those
incidentalomas? I like that.
Incidentalomas. And it's how do you deal with these things? And so a lot of it is experience and gestalt mixed with some parameters of what this should be and could be, and then knowing kind of what this patient, the presenting symptoms, and that's kind of where sometimes we have to get on the phone, call the doctor, say, hey, I found this. You know, how does this fit in the patient's overall picture? Well, maybe we should follow this or biopsy this. So there's a lot of collaboration between the imaging, the radiologist, and then those primary care guys who are, you know, they're in their office.
I want to move back to mammography for a minute. I know that Amy Robach and a lot of celebrities have been in the news recently. We've been hearing a lot about women who have breast cancer. And I think one thing that was interesting for a lot of us who followed that story was that she was basically going in for a screening. She's a young woman. And I think they found a primary tumor and then other tumors. Is that typical when you are looking, when you come in for a screening, all right, does it help you to have a baseline mammography, a baseline mammogram from somewhere else, or how does all that work? How do you begin?
Yeah, that's a great question. Well, obviously, if it's your first exam, that's going to be your baseline exam. But if you ever move, and I try to tell patients that if you ever move, take your mammograms with you, because the guy who's reading, or a girl who's reading your mammograms in the future are going to have those old films, because you know, sometimes cancer changes very subtly over time. And comparing those old mammograms, you can see the change over years as opposed to just 1 year, a year at a time. And so comparison mammograms are very beneficial and help make my day easier.
Okay, do they really make your day easier?
They make my day so much easier. So oftentimes, you know, we have to wait for some of these old mammograms to come in so that we can compare, see if they've been stable over time, if there's been any change, and then go from there.
Is breast cancer a slippery disease as far as, you know, I think, again, we as consumers sort of assume that if I have a tumor or I have a breast lesion, it's going to be so obvious that, you know, but obviously it doesn't happen that way.
No, it's not obvious. Sometimes these cancers, we cannot see those, we can't see them with mammograms or with ultrasounds. And sometimes it's just the physician or the patient can feel the
art of medicine.
The art of medicine. And unfortunately, there's just no imaging modality now that detects 100% of breast cancer. And so I think I've spoken with you in the past that mammography is right now, digital mammography and screen for mammograms are the only test that we have that's been proven to save lives.
Okay.
You know, we use other modalities like ultrasound and MRI as adjuncts to that.
Okay.
But as far as saving lives go, mammography has been proven to save lives.
Yeah, we did talk about that. Why are we not doing screenings with MRs? And you said it just doesn't, it's not necessary. It's sort of over-treating.
It is. It's a great question. Just MRI and ultrasound have a use is in the workup of breast cancer and the follow-up of breast cancer, but they just haven't been proven to save lives. Now, they may see cancers that mammography doesn't see, but they also lead to unnecessary biopsies.
It's very interesting. It really. We're going to take a quick break.
Sure.
Dr. Snyder, we're going to come right back. We're going to talk more about radiology. Very interesting subject. Stay with us on Healthy Living.
Pain. It can be different things for different people. A shoulder that takes you out of the game. A knee that stops you in your tracks. Ready to return to a better you? Hilton Head Hospital is here, right in the Low Country, to help heal what hurts. From diagnosis to treatment to full recovery, our fellowship-trained orthopedic specialists are committed to getting you back to your best. Hilton Head Hospital. Extraordinary care right here at home.
Hilton Head Regional Medical Center is located at 25 Hospital Center Boulevard. When traveling east on William Hilton Parkway, make a left-hand turn on Beach City Road, and the next left, Hospital Center Boulevard will be located just past the Hilton Head Library.
Coastal Carolina Hospital is located on US 278 at Exit 8 on I-95. Telephone is 843-784-8000. On the web, www.coastalhospital.com.
The vision for Hilton Head Spine Center is very clear. It's to provide world-class spine care to our patients.
Physical therapists were there. They were there holding you up. It's nice.
I just love working with all of these patients and their families and getting to know them and helping them on their journey.
My life is definitely better, and I'm glad that I came here at Hillhead Hospital.
We are back here on Healthy Living. We are with Dr. Jason Schneider today, and we're talking about radiology. And it's so funny, we have our whole little segment planned out what we're going to talk about, but we really want to know, and this is so interesting to me. Talk with me about the specialty of mammography, about the imaging that you do, because I know that you are, it's been really interesting kind of listening to your credentials and what sets you here at Hilton Head Hospital apart.
Well, I told you earlier that I did some specialized, focused training. I did a fellowship in breast imaging.
At MUSC.
At MUSC.
See, we listen to you.
I know. First time.
First time.
So at least somebody's listening to me.
Yes, exactly.
And so what that enabled me to do was, MUSC sees, there are a lot of cancers there, and it's cutting edge medicine there. And so being able to see how breast cancer is dealt with on a focused level. And that's something that I did not, I wasn't exposed to as much in my residency training, which was 5 years. And so that extra time gave me that training and that ability to be able to kind of talk the language with dedicated breast surgeons. I mean, it is a different language, and it's a different way of dealing with breast cancer. And so, it's been wonderful.
And so, from a credentialing standpoint, you really sit above the norm, if you will. Not to toot your own horn, but I mean, yes.
Exactly. I mean, as far as credentials
go,
it's just one of those things. I've been exposed to focused breast training.
One of the things here at the Bluffton Medical Campus that's so impressive, and we were talking about the collaboration that you have too, but it's brand new. Talk to us a little bit about the equipment that you have out here.
Wow, all brand new equipment. Brand new.
What's that like for you? Is it fun?
It is nice. Kid in a candy store. All brand new equipment. Brand new CT scanner, brand new ultrasound Acuson machine, which is beautiful. The best ultrasound images I've ever seen. Brand new nuclear medicine.
Is that the fluoroscopy one?
But we do have a brand new fluoroscopy. You're listening. Brand new nuclear medicine, brand new fluoroscopy. Everything is
so
just
you
shiny.
are a full-service radiology department.
Everything is full service and brand new here.
Well, that's so do you get to do a lot of different things too?
I do, and that's one of the great things about being here in Hilton Head as well, is that not only do I get to do all the, or most of the breast imaging here, but I still get to work with all the other physicians in the other modalities with CT and MRI and ultrasound, non-breast radiology.
Can you take us through, we talk MR, we talk CT, we talk all of these things. How are each of them used within treatment options or diagnostic options, I guess is what I really want to ask. Like, what is it? Dying to know what that fluoroscopy is.
Right. Wow, it's really using, there's multiple ways to skin a cat.
Okay.
And so each of these modalities has their strengths and weaknesses. And as physicians and as radiologists, we just use each one. It's a tailored exam to work up a certain type of clinical problem that may present itself.
So what are you looking at when you do an MR?
And so MR, MRIs, that technology has exploded. So not only are we able to look at the anatomy, but if you think of MRI, one of my professors used to say it's an experiment, because you're using a magnet, it generates this signal, and you're able to tell what type of cell or tissue that is by the signal it produces. And
okay, I'll tell you when I understand. Keep going.
Okay. And so if you look at a certain type of tissue and you expose it to certain types of magnetic fields, it emits a frequency at the atomic level.
I'm with you so far. Be scared.
That stuff, it comes out and it makes an image, and you're able to tell if is it solid, is it cystic.
Okay, got it.
It's a big experiment, and so that's kind of the fun, intriguing part of MRI.
When you do an MR, are you doing it specifically to your knee or your toe or your nose or your heart or your breast or whatever it is?
Anything, any body part, we can MRI, and even the vasculature. And we use it extensively to look at the aorta, the vessels in your neck for blockages in the neck,
carotid,
and then as well as the your vessels in your legs, where you know, we used to have to squirt dye down your legs to look at those vessels. Now we can put you in the magnet in the MRI machine and evaluate those vessels as well.
Now, what does a CAT scan do? What are you looking at with a CAT scan?
That's the CAT scan is an X-ray machine, but if you think of your body as a loaf of bread,
okay,
it shoots an X-ray each little slice.
Okay.
And so the whole study comes out as a loaf of bread.
I got it.
And then we're able to go at each slice and look from stem to stern, head to toe, what's going on, from your head all the way down your neck.
So the MR is looking at my spleen as an organ. A CAT scan, an MR is doing that.
Right.
A CT scan will look at my spleen
in little slices.
It's like, oh, okay.
That's generally.
Well, I got that. Right. Yeah, exactly. Yeah. For us, for the sake of the interview, that's what it is. Okay. Ultrasound.
Ultrasound, where the MRI uses a magnetic field, CT uses X-rays, ultrasound uses ultrasound sound waves, and so depending on how fast those sound waves come out of the little probe, it hits something, bounces back, and the computer is able to tell whether it's a cyst or is it fluid, solid, bone, air.
I'm thinking baby.
Right, exactly.
Right.
And it's neat. I mean, it's so good at detail. That's why we're able to use it with children. You know, small little baby.
Oh yeah.
Small little hearts.
Yes.
Small little kidneys. So we're able to see some fine detail without exposing that child to any radiation.
Oh, I never even thought about that. With mammography, is it an excellent tool for you?
It is.
And why would that be specifically? So you screen with a mammogram first.
Right.
You see something suspicious.
Right.
Then do you do enhancements next, or what's a typical procedure?
That's a great question, because I get that question all the time. So, you know, a screening test is just a test. We want to see a lot of people get this exam, knowing that most of these are going to be
routine, boom,
routine.
Fine.
There's going to be a small percentage that something is different than the last mammogram. So we bring those patients in and do a tailored exam. We call that a diagnostic mammogram.
Okay.
Sometimes we need, after the diagnostic mammogram, we need additional imaging. So we may need an ultrasound to look at that.
All right.
And so generally after those two exams, if you need an ultrasound, then we've come to a conclusion, whether it's something that is benign and we'll get you back on your yearly screening mammogram.
Okay.
Something that needs to be followed up, it's probably benign, which means it's less than 2% chance of being breast cancer, which is a small number.
Yes.
So we'll just keep an eye on it, we'll look at it again in 6 months.
Okay.
Or it's something that warrants a biopsy.
So after I have my screening mammogram, and then the ultrasound is used as a further screening tool as opposed to being a diagnostic tool?
It's used as part of the diagnostic process.
Okay.
And so, and again, it may or may not be part of the diagnostic process.
Then do you do like a stereotactic biopsy? Do you do those?
That's a great
here?
question. If it's something, we do that here. All the biopsies we do.
Do you do that?
I do. We do stereotactic biopsy, which is a fancy word for a mammogram machine.
Okay.
The ultrasound biopsy.
Okay.
You know, we use the ultrasound machine to guide the little needle in there. And then we do MRI biopsies. We use the MRI machine to guide the needle in there.
Okay.
So generally we use, generally speaking, the machine that allows us to see that abnormality the best. And so that's how we decide.
Is there a lot of intuition in what you do also? Do you ever see an image and just kind of get a feeling that if I look a little
I don't like that.
Oh, it's a bad thing.
I don't like that. I want to look at that again.
Okay.
I want to look at that closer. I think there is certainly some intuition, but just knowing that there are also parameters and guidelines that you use, and it's been set up already for us. We call it the BI-RADS lexicon. That we use that as a guideline to look at these images, these screening mammographic images, these diagnostic images.
It's so interesting to talk to you because I think for some reason it takes the mystery and a lot of the fear out of everything by you just talking about this as a...
And just knowing that just because if you have a diagnostic mammogram and a callback, it's not an ominous sign. We want to look at something a little closer. Even if you're recommended to have a biopsy, that's not an ominous sign, knowing that 80% of the biopsies that we do are benign, and that's what you want. Those are my percentages. I want to be 20 out of 100 of the biopsies I do need to be cancer. Okay.
It's so interesting. Dr. Snyder, thank you for joining us. We want to
You're
thank all
welcome.
of you for joining us here on Healthy Living. Have a great week.